Courvoisier law was given by Ludwig Georg Courvoisier, born in Switzerland. He practiced surgery as professor in Basel. He developed interest for biliary surgery and described 187 cases of common bile duct obstruction and observed that gallbladder dilatation seldom occurs with obstruction of common bile duct. Current version of Courvoisier law is usually defined as a palpable non-tender gallbladder in a jaundiced patient suggests malignant obstruction of common bile duct. The classic explanation for Courvoisier's finding is based on the underlying pathologic process. With the presence of gallstones, come repeated episodes of infection and subsequent fibrosis of the gallbladder. In the event that a gallstone causes the obstruction, the gallbladder is shrunken owing to fibrosis and is unlikely to be distensible and, hence, palpable. With other causes of obstruction, the gallbladder is distended as a result of the back pressure from obstructed bile flow. Arguments against this states that gallbladder is not capable of such massive distension without giving rise to liver failure due to high intraductal pressure. However, it is seen that the progressive, initially incomplete nature of malignant obstruction ensures that pressures build gradually without precipitating liver failure. Chronically elevated intraductal pressures are more likely to develop with malignant obstruction owing to the gradual, progressive nature of the disease. Gallstones, although also able to cause obstruction, do so in an intermittent fashion, generally not consistent enough to produce such a chronic rise in pressure. There are some exceptions to Courvoisier's law. Calculus obstruction in Hartmann's pouch with another in CBD. Gallbladder obstruction causes mucosal and palpable gallbladder. Chronic pancreatitis. Fibrosis in pancreatic head may cause biliary stricture and gallbladder distension. Autoimmune pancreatitis. Pancreatic head edema may cause biliary compression and gallbladder distension. Parasitic biliary obstruction like Ascaris leading to biliary obstruction. Acquired immunodeficiency syndrome. AIDS. Associated cholangiopathy. Congenital choledochal cysts. Common hepatic duct obstruction. Proximal to the insertion of the cystic duct. Malignant jaundice with no gallbladder palpable. Double pathology. Distal malignancy in the presence of a fibrous gallbladder like xanthogranulomatous cholecystitis. Subscribe to our unique YouTube channel dedicated to learning about cancer, concepts of oncology, simplified informative videos, high yield facts, case discussions, new videos strictly 2 times a week, useful for exams, lectures, updated informations from recent edition books, journals and guidelines.